So I'm Richard Payne from the Center for Practical Bioethics in Kansas City and Duke University. And this is panel 2, is palliative care across settings. I'm going to follow Charlie Sabatino's lead and not introduce the panelists because first of all, I would be astounded if people in the room didn't know who they were. And secondly, you have their descriptions. So we do have a panel who has done and continues to do, really important work in palliative care. We have a situation now where we have palliative care, which started as essentially a hospital-based kind of approach and service that now expanded into other venues, and that's very exciting. There are issues, though, that have emerged and are emerging with respect to variability and quality, with respect to penetrance to underserved groups, and also issues, I think, which are emerging around consumer and public understandings and attitudes about palliative care, which I might say something about at the end. But given that as an introduction, we will go right into the panel, and the order will be, we'll have Sean Morrison speaking first, then Bob Fine will follow him, followed by Joan, and Ira Byock will close, and then Joanne Lynn will respond. So, Sean?
Good morning, everybody. Thank you for the opportunity for being able to talk with you today, and it's really a pleasure to be on this panel with some sort of very distinguished colleagues and friends. What I thought I would do, and I was told 7 to 8 minutes, is begin to set the stage for the next 3 commentators. And I guess I was sort of surprised this morning to realize that actually nobody talked about a patient. So as a physician, I want to talk a little bit about a couple of my patients, which I hope will frame the conversation that you're going to hear about. So the first is, for many of you who don't know me, I'm a geriatrician and palliative medicine physician. So let me tell you a little bit about one of my geriatrics patients. This is a guy named Mr. H, who again gave me permission to share his story. Actually, his wife gave me permission to share his story. He's an 88-year-old gentleman. He has dementia. And he came into our ED about 6 months ago with an exacerbation of his emphysema. He basically came in not being able to breathe. His breathlessness was 8 out of 10, pretty severe on admission, and he was sort of puffing an inhaler not very well without any benefit. And his 83-year-old wife told our team when we first saw her that she was completely overwhelmed. This was his 3rd admission in the past 6 months, 2 of which were for breathlessness. Two again were for a fall at the same time. He got breathless and he fell down. And 1 was for confusion and delirium in the setting of a urinary tract infection. And when we met Mr. B and talked to him, the first thing he said was, "Please do not take me back to the hospital again, please." And his wife says, "He says that every time we come in." And she said, "He hates the hospital, but what could I do? The breathlessness was terrible, and it was 9 o'clock at night, and I couldn't reach the doctor." Do you know what happens when you try to call the doctor in New York City in the middle after 5 o'clock? You get a message that says, first off, if this is an emergency, call 911. And then you have to wait for the next part of the message that says, if it's not an emergency, please wait. And he couldn't breathe, so it was an emergency. And she says, so I called the ambulance. It was the only thing that I could do. We know that the care of persons with serious illness needs improvement. We have 4, now going to be 5 IOM reports that have documented how poorly we care for people with serious illness in this country. We know that over the past 10 years, people with serious illness have a high symptom burden, tremendous psychosocial needs, tremendous mismatches between what patients' stated goals of care are and the treatments that they receive. And yet we haven't seen dramatic, I would say we've seen substantial but not dramatic improvements in care. And we are spending a tremendous amount of money to get these results. almost 20% of our gross domestic product is going to healthcare in this country. And many, I know others in this room have said that I think the single biggest threat to the American way of life is what we spend on healthcare. And again, no surprise to most folks in this room, it's 5% of the population that's driving almost 50% of healthcare costs. And it's the population we're talking about today, or at least part of that population. And I do want to dispel a few myths, because everybody now is familiar with that 5% figure, right? We've all heard it. But actually, when you break down what's in that 5%, almost half of those folks are people who have a single episode of care and then drop back down into the low spending group. So it's the folks that get liver transplant, big operation. It's only 10%, 11% who are actually at the end of life. It's only 10% who are the folks that are dying. And the remainder, that 40%, are folks just like Mr. B. It's folks with functional limitation, dementia, frailty, serious illness, and the vast majority are not in the last year of life. I am very conscious, given the remarks we've heard this morning and where we are, about the importance of language and the importance of the population that we're trying to address as patients and families. And we have a lot of data now from folks with serious illness that end-of-life care doesn't resonate well with them. Having a better death doesn't resonate well with them when they're living with a serious illness. And we need to begin to address that. And I'm going to come to my second patient in a minute. So how have we begun to address that? First of all, we have great care for people who are dying at the end of life. It's called hospice. There is nothing that we can't do. What's the problem with hospice? We can't get people into it. But once they are there, it is not a problem. It's taken care of. What we need to do is bridge and make that transition. So how do we do that? We began, as somebody said, with hospitals, and that's where palliative care teams started. That's because there was a business case. And we now have, over the past 10 years, a conclusive body of evidence that hospital-based palliative care teams do what they want, what we want them to. They improve quality of life. They help patients and families. They assist transitions to the community. And right now, 90% of our mid to large size hospitals have palliative care teams. So we have made a huge progress in that matter. There's not enough penetration. All teams are not created equal. They're not all providing high quality care, but the infrastructure is there. And I would suggest that we are well past the tipping point there. We have a couple things that we need to do there. We need some strong quality metrics for hospitals. Groups in this room, Neil, Joan, have developed the quality metrics that we need around pain and symptom management, around goals of care discussions, and around transition. What we need is the National Quality Forum, which has endorsed them, and CMS to start putting those into practice. We have enough that we can do a much better job, and we need that forward. We need the Joint Commission to decide that having a palliative care team is a necessary requirement for hospital accreditation. I would not go to a hospital in the United States that didn't have an emergency department or didn't have an ICU. If I had a serious illness, why should I go to a hospital that doesn't have a palliative care team? That strikes me as insane. And thirdly, we do need, and Laura Hansen talked about this, the workforce. Particularly within our academic medical centers, we need the educational input. So, as we think about moving forward beyond hospitals, what do we need? And I think my other colleagues are going to talk about that. First of all, we need regulatory and accreditation requirements that span the continuum. We have strong programs in hospitals. We have really strong programs in hospice. We need something in between. As my second patient said to me, and this comes back, who happened to be Woody Allen's producer, and I'm allowed to tell you that, he said, you know what, I have really mixed feelings. His wife died in hospice in Vermont in the 1980s. He says, I can't wait till I can get the coordinated care of hospice. On the other hand, I don't want my disease to progress to the point where I need it. And he said his biggest struggle was trying to coordinate care, I met him on Friday, was trying to coordinate care in the setting of a serious illness with multiple symptoms without the benefit of hospice because he was still receiving disease-remittive chemotherapy, which, by the way, was working. And he was living at home. And his son said, we've been hospitalized 6 times. We need the added layer of support that palliative care provides because we just can't make the system work. So we need that community-based support, and we need quality and accreditation requirements. We need the right quality metrics linked to payment. Joanne has talked about this a lot. What terrifies me about all the move towards risk with hospitals is we do not have the quality metric safety net to take care of our patient population, to ensure that as we reduce costs, we're not improving quality for this group. We need a system redesign. We need to figure out how we're going to allow patients with serious illness to transition across the community, and we need palliative care integration into all these new delivery models, because right now there are no major incentives from the CMS and others to do that. And I will stop there because I think my time is up. Thank you very much.